All right, we're going to move on and start talking about breathing mechanics here in lecture number 5. What actually causes us to breathe? And again, as you recall from an earlier lecture, the actual act of inhaling and exhaling air is called pulmonary ventilation. That's one of those 4 processes of respiration. And there are 2 phases, inspiration and expiration. Inspiration is another term for inhalation. Expiration is another term for exhaling. So during inspiration, gases are flowing into the lungs, and during expiration, gases are exiting the lungs. And so what makes that happen? Well, it all revolves around pressure changes. Pressure dictates airflow. You're having to move air in and out of the lungs, and so something to learn early. We're not going to go into this as deeply as your textbook is, so just keep that in mind. If you're reading along in your textbook, there's going to be a whole lot more numbers and mathematics involved with airflow and pressure changes. We're going to kind of keep it simple. But something that's important to remember is air is going to flow from higher pressure to lower pressure. And that's not hard. That's just common sense. I mean, think about if you had a balloon filled with air, and if you squeeze the balloon, you put more pressure on the air in the balloon. That's high pressure. Where's the air going to go? If you don't have the balloon tied off, the air is going to flow out of the balloon because the surrounding air pressure is going to be lower. And that's how your lungs work as well. In order to take air into the lungs, we've got to make sure that the air pressure in the air surrounding us is higher than it is down in the lungs. That's going to make air flow inward. When we're going to exhale, we've got to squeeze the lungs so that we increase the pressure in the lungs and force that air outward. So here are some numbers about typical air pressures that you have in the lungs. So air pressure is measured, we've seen this before, millimeters of mercury, just like we measured blood pressure, except the numbers were quite a bit lower with blood pressure. But typically your air pressure inside the lungs is 760 millimeters of mercury. The pressure in between the lungs themselves and the walls of the pleural cavity walls, is typically about 756 millimeters of mercury. All right, so what do we notice? The intrapulmonary pressure, the air pressure inside the lungs, is a little bit higher than it is in the space between the lungs and the walls of the pleural cavities. And if you think about it, that makes sense. You want the air pressure to be a little higher in your lungs. Your lungs are pretty delicate. They have to be able to expand and collapse to allow you to breathe. So if your pressure was actually higher out in here, then it would cause the lungs to collapse. And that's not what we want to happen. So under normal circumstances, you have a higher pressure inside the lungs as opposed to the space and the pleural cavity surrounding your lungs. And that also helps keep your lungs fully inflated, which is why when we talk about that pleural cavity space there, it's a potential space, and it's extremely, extremely thin because usually the lungs are inflated. All right, what happens though if you do wind up with air pressure that's higher in the pleural cavity surrounding one or both of your lungs? That can lead to atelectasis, which is a term for lung collapse. And when that occurs, that's not a good thing. I'm sure we've all heard of somebody before with a collapsed lungs or a collapsed lung or lungs. And the reason that can happen, a couple of major reasons. One is if bronchioles Those tiny bronchi lead to bronchioles, which lead to alveolar ducts, which lead to your alveoli if you're thinking about the airflow down into the lungs. And so if those are blocked, well, think about it, you can't get as much air down deep inside the lungs. So if your bronchioles are congested, like let's say you have very severe pneumonia and you have overproduction of mucus and fluids from inflammation down in your lungs and you can't get enough air down into your alveoli, that can lower the amount of air that you have in your lungs. That can lower the air pressure. And if the surrounding pressure in the pleural cavity winds up being higher, it can cause the lung to collapse. Another term you guys should be familiar with is pneumothorax. If you have any kind of wound that punctures the wall of the pleural cavity and allows air to flow from outside and into the that pleural cavity surrounding the lungs, that's also going to increase the air pressure in there and cause pneumothorax, which will collapse the lung as well. That can happen sometimes like with in stabbing victims or in gunshot wounds. You know, if you puncture the wall of the thoracic cavity, but you don't necessarily puncture the lung itself, that can cause lung collapse when that happens. All right, so breathing, inspiration and expiration, inhaling and exhaling. As we're going to see, inspiration is an active process. And by active, it means it requires muscle contractions to take place. Expiration or exhalation is a passive process. It involves relaxation of the muscles that are involved in breathing. All right, so why is it? Sometimes that sounds the opposite of what we might think, but here's how this happens. If you look at this diagram over here, what's your main breathing muscle? Hopefully you know that's the diaphragm. And the diaphragm kind of looks like a parachute. Looks like that. And when it contracts, it flattens out. That's what they're showing you there on the left side of that diagram. It flattens out. And so what's going to happen to the size of the thoracic cavity or the volume of the thoracic cavity? If your diaphragm, when it's relaxed, is up here like this and it flattens out, then the volume of the thoracic cavity increases. All right, now let's think about the relationship between volume and air pressure. I'm going to erase what I wrote over here because this is something you guys need to keep in mind as well. It's another one of these rules with airflow and gas pressures and so forth. If your volume increases, your pressure goes down. If your volume decreases, pressure increases. Okay, that's one of these relationships. It's called an inverse relationship. If one thing goes up, the other thing goes down. So think about it, that makes sense. All right, think about a balloon. If you compress a balloon and that balloon is open, the little nozzle up there is open. If you press on the balloon, what are you doing to the volume? You're making the volume smaller. What's happening to the pressure inside the balloon? The pressure is going up. So where is the air going to flow? It's going to flow outward. On the other hand, if the volume of the balloon expands, your pressure actually will go down. If you squeeze it, pressure goes up, but if you allow the balloon to expand, the pressure actually goes down within that compartment. So that's why as you expand your thoracic cavity, you increase the volume inside the thoracic cavity, the air pressure in there goes down. So what's going to happen to air? Your air is going to flow into the lungs because as the diaphragm flattens out, air pressure inside the lungs goes down compared to the outside, and so air flows into the lungs from the higher to the lower pressure. The opposite happens with exhalation. Exhalation or expiration is a passive process. So as the diaphragm relaxes and moves back upward like that, what's happening to the volume of the thoracic cavity? It's getting compressed. So even though you're not contracting the muscle, it's relaxing, it's still squeezing the thoracic cavity. That increases, that lower volume increases the pressure in there, and that forces air out of the lungs and back to the surrounding air. Okay, and also I want to point out to you, there are other muscles that are involved in breathing, and you probably talked about some of these when you were studying skeletal muscles in Biology 201. If you guys remember your intercostal muscles, they're not shown there on the diagrams, but you have intercostal muscles in between the ribs, and as they contract, they also help to pull on the ribs and expand your thoracic cavity. So they're also involved in increasing the volume so that the pressure goes down and air will flow into the lungs. And then as those muscles relax and the diaphragm relaxes, that's also helping to decrease the volume of the thoracic cavity, which forces air out of the lungs. Then you have some other muscles that are involved in deeper breathing. If you guys remember from Biology 201, you may have talked about your pectoralis minor muscle that's deep to your pectoralis major muscles, which also pulls on the ribs and helps to expand the thoracic cavity during deep breathing. And there's one more you may have talked about, your sternocleidomastoideus muscles, those long muscles that run from the mastoid processes of your temporal bones down here to the top of the sternum and the clavicles. And ordinarily, those muscles pull on your mastoid processes. They're your nodding muscles. But during deep breathing, they can reverse the direction that they're pulling. They can actually pull on the clavicles and the sternum and help you inflate your thoracic cavity maximally during super deep breathing. You can feel that if you put your fingertips here along the sides of your neck and breathe in as deep as you can. When you get to this point, you can feel your sternocleidomastoideus muscles contracting, because that's they're only used during the deepest breathing. Also, your abdominal muscles. Think about if you your abdominal muscles are contracting, that also gives your thoracic cavity more space to expand. If your abdominal muscles are squeezing that abdominopelvic cavity and reducing the volume a bit. And that's why your abdominopelvic muscles, your abdominal muscles, can hurt when you've been running or exercising vigorously for some period of time, because they start to develop cramps from all of that contraction that they're doing. Okay, some of the factors, 3 major factors that are going to influence pulmonary ventilation. Your inspiratory muscles, your diaphragm, your intercostal muscles, and those other deeper breathing muscles that get involved. They have 3 things that they have to overcome in order to do that properly. One of those is airway resistance. So do you have blockages of any kind? Resistance to airflow. A good example, if you have pneumonia or bronchitis, you're going to have lots of mucus and fluid in those air spaces, and that interferes with airflow. That's a type of airway resistance. Alveolar surface tension. We'll talk about those. Alveoli are super thin. I like to think of them almost like they're even thinner than Kleenex, and they're very moist. Now, what do you know about wet Kleenex or wet tissue paper? You can't keep that as a nice, thin, even sheet of paper when it's wet, because that sheet of wet Kleenex or tissue paper wants to just cling to itself. Same thing with your alveoli. Alveoli have a lot of surface tension that has to be overcome in order for breathing to function properly. And then finally, lung compliance. This is really referring to how easy it is for your lungs to expand. They have to be able to stretch and expand. And there are some disorders that can occur where the delicate tissues of the lungs are replaced with scar tissue that's very fibrous, and that makes your lungs less expansive, and that can reduce what's called lung compliance. All right, so we'll talk about these in a little bit more detail. Airway resistance. Okay, so anything that increases airway resistance is going to make breathing more strenuous. It's going to make it more difficult to breathe. That just kind of makes sense. So anything that is constricting, obstructing your bronchioles, these are also called, we're going to see obstructive breathing disorder later. Anything that's blocking this airflow. So in severe cases, it can actually prevent proper ventilation. That's why you can die from something like pneumonia. If you have so much mucus and fluid down in the lungs and it's interfering with ventilation and proper airflow, that's going to kill you. It's going to cut off your ability to take in enough oxygen and to get rid of the CO2. I want you guys to start thinking now about getting rid of CO2 is super, 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 super important as well, because that CO2 winds up being toxic very quickly if you don't get rid of it. Also, when people have asthma attacks and their air passages constrict, that's a type of airway resistance as well, because it's blocking ventilation. That's why epinephrine counteracts that. Like if somebody is experiencing an asthma attack, they carry around EpiPens with them. One of the functions of epinephrine is to dilate air passages. So your bronchial passages have smooth muscle tissue in them which can constrict, and epinephrine causes it to dilate. And that's one of the actions of your sympathetic nervous system, which makes sense when you think about it. Sympathetic nervous system, fight or flight. So if you're in a fight or flight situation, you want your bronchial passages to dilate so that you take in more air. So epinephrine, that's the natural function of it, but it can be given to people who are having asthma attacks to very quickly dilate their air passages when they're having an asthma attack. When you have an asthma attack, the smooth muscle not only may you have mucus buildup going on for some reason down in your air passages, but an asthma attack, you have some sort of a severe allergy to something, and those types of things trigger constriction of your air passages. And that might seem kind of contradictory, but let's say that's a protective thing naturally, because if you're breathing in something that's potentially toxic, it could be life-saving to you for your bronchial passages to actually constrict and prevent more of that toxic air from making its way down deep in your lungs. When you have asthma, that is happening inappropriately. So you're having an inappropriate bronchoconstriction going on that's preventing airflow down deep into the lungs. Surface tension. So I just mentioned this a minute ago. Surface tension, things that are covered with water tend to have a lot of surface tension because water is attracted to other water molecules. They love to interact with each other. And the wet Kleenex analogy is one I was using a minute ago. Think about your alveoli as being composed of tissue paper, even though it's even thinner than that. And it's very moist. Those are moist surfaces. So those walls of those alveoli are very strongly attracted to each other. This is where your surfactants come in. Remember we said those are produced by the type 2 cells in the alveoli. And that functions kind of like a detergent. It's a detergent-like liquid. Lipid, it is a liquid, but it's also a lipid. And it helps prevent or reduce that surface tension among the walls of the alveoli so that they're not so strongly attracted to each other. It helps keep the alveoli open. And this diagram is showing you what would happen to the alveoli of the lungs if you did not have adequate surfactants down in that location. This can be a problem. It was actually a problem with my firstborn daughter. Sometimes newborn infants don't produce enough surfactant if they're ill, or premature infants don't produce enough surfactants in their alveoli, and that can lead to lung collapse because of that. As the alveoli collapse and you can't take in enough air into the lungs, that can lead to a collapse type situation developing. All right, lung compliance. How compliant are your lungs? This is a measure of the change in lung volume that occurs during inspiration versus expiration. How well can you inflate and deflate your lungs? That's going to impact, it's just kind of common sense. The better you can inflate your lungs and the better you can deflate your lungs, the better ventilation you're going to have. And normally in a normal healthy person, this is high because your lung tissue is very expandable. It's also very elastic, so it's going to rebound to help deflate the lungs. And also because of the alveolar surface tension, that actually helps out with, even though we have the surfactants in there to prevent lungs from collapsing, the fact that the alveolar walls will get really close to each other, that helps you move air back out after your lungs have inflated. So over time, lung compliance goes down, and some of that's just due to natural aging. You have healthy lung tissue that gets replaced over time with aging tissues, and your lungs age just like other parts of your body, and that's going to reduce your lung compliance naturally. It's one of the reasons why you can't exert yourself as much as you get older. But then there are disease states that cause lung compliance to get worse. Fibrosis is referring to replacement of expandable lung tissues with scar tissue that has a lot of fibers in it, so it's just not as expandable and not as reboundable. Or if you have reduced production of surfactants, you might wind up with alveoli that stay almost completely collapsed or completely collapsed all the time. Also, anything that reduces the flexibility of your thoracic cage, like let's say you had a severe burn or injury and you have tissues like your skin tissue around your thoracic cavity gets replaced with scar tissue, and your skin is not as stretchable anymore, that's going to limit your ability to expand your thoracic cavities and take in as much air. So all of those are features of lung compliance. How much can you change your lung volume when you're inspiring and expiring air? That's going to bring us to the next topic, lecture number 6, which is on respiratory volumes. And I encourage you to follow along with this lecture as closely as you can, because respiratory volumes can be a little bit confusing. So we'll cover that in the next video lecture.